That's better. I think you're going to need to wag this side a little further north and bring your base further south. So folks, what we're doing right now is we're trying to position the fluoro machine so that I can navigate safely to where I need to be. We're not far off, guys. We're pretty close, but there's still a double shadow on the top of the pedicle of L5 that we need to fix. So this surgery we're doing requires something called navigation. Navigation in surgery means getting to a place that you need to go to. So you're navigating. And just like if you're, no, the opposite. It's like if you're navigating a ship around islands or rocks or a coral reef, so you don't, that's better. I still think we got a wag issue. And we still have a rotational issue. Look at the S1 pedicles, they're offset. So we need to rotate and we need to wag a little bit. Let's start with the rotation. It's the other way, I think. So just like you have to navigate safely your ship around islands and rocks and reefs, I don't know. It kind of looks, I think, I want to say worse, but let's keep going and see if we can get any better than that. And what, in effect, what we're navigating in surgery is our instruments. We're navigating them to the, you know, the 5 looks pretty good, but the S1 doesn't look. I think you're in the right direction, though, maybe. Go a little further. Let's see if you can bring it together. What I'm looking at is the back of the sacrum. It doesn't seem to be making much improvement. Maybe the other way. 5 was nice. Shot. It looks like a little tube snaking around, but that's not. That's just a drain tube sitting on top of the field. All right, I think we had it better. And we need to change the wag because the pedicles are not superimposed anymore. So the navigation part is, the starting point is the skin, and the ending point is the herniated disc we're trying to fix. I think it's worse. A lot worse. So I'm navigating from the outside, or the skin surface, the entry point we call it. Let's just call it the entry point. I'm navigating from that point. All right, let's try that. Let me see the wag. I think we're still off a little bit. Right, before I do that, let's move this tube. That's good. Shot. Let's just see where we are, because I think the tube was getting in the way. All right. I think the pedicles of 5 are still bad. So let's see if we can't get it better. Shot. Shot. That seems to be worse. Let's see. Shot. Definitely worse. Shot. That may be the best we're going to get right there. Let's lock it down. There's still a rotational anomaly. I wonder if we can get a little better. Let me have control of the arc. Shot. That's better for some reason, I think. Let's just lock it there. All right, so if you could see the fluoro machine, you'd see that the beam is actually, normally it should be completely flat and even horizontally, but it's not, and that's because the spine is so twisted. Are you comfortable? What'd she say? Let me know if it hurts you, okay? Shot. So I've got to navigate down. It's a little overexposed. I mean, just a little bit. Not too bad. I could live with it. Sean, that's it. All right. So I got to make my way down to the pedicle. I mean to the disc. Sean. And again, it's going to be immensely challenging because of her rotation and her arthritis. I'm just wondering if I can improve that a little bit more. The disc is collapsed at L3-S1. She's doing fantastic. Shot. You're doing great. Everything's okay, Sean. This is if you do endoscopic spine surgery, this is as hard as it gets. It doesn't get any harder. Sean. Get an AP. So L3-S1 is the hardest level to gain access to and do. The very few transforaminal endoscopic spine surgeries in the world that there are, there's probably only a handful, like 20 of them. Okay, that's perfect. Go back to a lateral. The 20 endoscopic transforaminal lumbar spine surgeons, there may be 20 in the world at most. And there's more of them in Asian countries like China and Korea than United States. Those doctors, they don't do L3-S1. They go translaminar at L3-S1. Is that hurt? Shot. Let me know if it bothers you. You're doing great. I'll let you know how we're doing, okay? Everything's going well. Just lay still. You're doing fantastic, Sean. You know, I heard everything in Texas is big, and what you're showing me is what's called a big curve. You know what a big curve is? No, it's not good. You have a big curve to your spine. But don't worry, we're not giving up easy. We're gonna get in there. You just lay still and we'll get it done, all right? Let's get an AP. You're welcome. So, as I was saying, the few spine surgeons in the world that do transforaminal surgery, they don't do L3-S1 transforaminal. They do it interlaminar. They go between the lamina. And that's a worse procedure. Back to a lateral, please. Interlaminar is much worse than transforaminal because you have to remove bone and ligaments from the spine. Anytime you go what's called translaminar or interlaminar between the lamina, you're going to be removing bone and ligaments from the spine. All right, before I change my position, I want to do a little wagging myself and see what I can come up with. Shot with just about 1 degree. Do you think that's better or worse, Luis? Yeah, I agree. It's just look at the L5. I think S1's better. I think I'll leave it. Lock it. I'll take it. Are you comfortable? Yeah, just lay still. Don't lift your head up. You feel anything at all? Sean? Huh?
She said yes.
Where?
At your ass cream.
At what?
At the top of
Her butt. Not down your leg? AP.
Yes.
Nothing down the leg. Yeah. It'd be the left leg that I'm worried about. So because that's the side we're on. And this is why the patient has to be awake for the beginning, without exception, is the fact that we're navigating through the foramen right near the nerve root. And I don't want to touch the nerve root. And if I do, anything? Where?
The last one hurt?
You have any pain down your leg? No. Shot? Lateral. Well, if I'm in, again, I guess with age comes luck. I shouldn't be able to do this stuff, but somehow it's happening. I say God willing because it is God's will. I just can't believe we got in. It's amazing. I'm not patting myself on the back. Trust me, I don't have the skill to do it. It's divine intervention. Well, I think you got some, Shot. I think you got some divine intervention. God is definitely on your side. We just got into your bottom disc, and I don't know. I couldn't have done it on my own, that's for sure. So you've done a great job and laid still. So let me know if it hurts, okay? We're going to make our incision now. And the incision we're making is going to be 7 millimeters. That's it. The whole surgery is done with a 7 millimeter incision. No. Oh, you've done these, right? No. So I apologize. I'll just tell the audience, what we're doing here is we're fixing 3 discs. So we have to access all 3 discs. We have to navigate from the outside world, our point of entry, which is right here. This is like a point of entry, our port. It's like a little airport here where all the needles are taking off from. And we're going to get into the 3 discs. Now I may have to make a second incision depending on the curvature. It's not uncommon with such severe scoliosis. I'd have to do a second incision. But we're going to try to get them all from here. So now that we're in the bottom one, and I verified that by doing a little discogram, just a tiny bit of dye, now we need to navigate to L4-5. So I need Jordan to do his job of shifting the fluoro so that the end plates of L4 and L5, the L4-L5 disc is parallel to the beam of the fluoro machine. Look up on that last image, you could see 3-4 was parallel, but 4-5 was not. So, we could do 3-4 and then come back and do 4-5. So let's go ahead and go back to where you were. It's not far from where you are now. Take a shot. And maybe we'll just do 3-4 real quick since we've got it lined up beautifully. The only problem is I don't know if I can get there. All right, so we make an incision. We get all 3 of our positioning needles in place. And then shot. And then we put the patient to sleep. So we're not quite ready yet. Shot. Shot. It's a little higher than I want to be. Shot. That's better. I'm on the facet. Shot. I rotate, deflect. It's really not a forced technique. This is a very delicate technique, by the way. It's really about, there's really no better word other than finesse. Sean? You have to finesse the needle to the exact spot. Sean? All right, so let's get an AP. So now we're at the 3-4 disc. We're fixing 3 discs in this patient. 3-4, 4-5, 5-1. We got lucky. We got into 5-1 nicely. All right, so we're too far lateral. We need to go more medial for 3-4. All right, so let's go back to a lateral. Luis got excited. He thought we were ready. But that's why you have to do, folks, when you do this type of surgery, you have to use your fluoro for navigation, and you can't just rely on one view. You see the lateral view at 3-4 looks like the needle's in the perfect position in the back of the disc. But in reality, because of the curvature of the spine, that needle is far from being in the perfect position. And had we proceeded, it probably would not be good. So I may need to make a second incision. I'm going to try again. I'm going to try with this one. Let me have a needle a knife. I may extend it a little more medial. The problem is the spine is curved away from me. So it's like trying to get away, but it's not, because that's her natural curve. So if I just, hold on, if I just open it a little more, I can maybe avoid having to do a second incision. Otherwise, I'm going to have to do another incision somewhere around here. Okay, so let's see if I can reach from the corner and be successful at getting all the way over, because remember, her spine is shifting. It's not shifting now in surgery. It's shifted over the years of arthritis. Shot, and the curve is curving away from the left side, which is where I am. Shot, which also causes the left side to be what's called a small curve. And the small curve is where you get the pinching of the nerve. Shot, usually the pinching of the nerves. So, shot. Again, if I can't reach it this time, I have to make another shot, another incision. But I'm feeling the facet joint. Shot. Perfect. Let's see. Shot. We're just taking our time, finessing. Shot. Now I feel like I'm in the foramen. I feel a herniation right there. So let's get an AP. I think it's a herniation. Let's see where we are before we go any further. So when you do this type of surgery, you're using the fluoro to navigate, because otherwise it's impossible to know where you are. Yeah. As ugly as it looks there, it's actually looks pretty good. We're in the right spot. We're just at the medial border of the pedicle. All right, let's go back. So I believe I am feeling the herniation here. So let's see. Are you okay? Shot. Do you feel any discomfort? Where is it? Huh? Not down her leg. All I want to know is if it goes down her leg.
Not down the leg, right? No, not down the leg.
Shot? Definitely at the back of the disc. Shot. Up against. Shot. You comfortable? Is that a yes or a no? Shot?
She said she's fine.
All right, good. Shot. This side is so collapsed. Yeah, keeps getting deflected. Question is why? What am I not seeing? Shot. Let's wag it a little bit. It must be missing something on the bottom pedicle. It must be the scoliosis between these two levels. Let's see if we can bring the pedicle down. Yeah, a little more of that. So the bottom pedicle, the pedicle below the needle, is the one that's completely off. And that's why I'm having trouble. Now that's better. So I'm hitting the bottom of 3. That's the problem. I'm hitting the bottom of 3, end plate basically. Shot. I want to aim down. See if that makes it any better. Well, very collapsed. So I'm right there. AP. And I think if she was asleep, I could get in. Are you feeling any discomfort? Okay. So when she's asleep, her muscles will relax a little bit. Yeah.
We have a question.
Yes.
One of our viewers is wondering, what is the aim of doing laser surgery in this patient?
The aim. The goal of the surgery is to eliminate her back pain and her leg symptoms, and both are coming from the disc herniation at these 3 levels. And that's what our aim is to go and repair the herniated discs that are causing her pain. Her symptoms are not coming from the scoliosis. They're coming from the disc. So we're going to go in using the endoscope and the laser, and I'm going to repair the tear in the back of the disc that's causing her pain. It's called an annular tear. All right, so we are just past the medial border of the pedicle. Let's go ahead and get a lateral again. Are you okay? Again, no leg pain, right? Shot. As with all Duke laser disc repairs, the goal is to eliminate the patient's back pain, leg pain if they have it, or neck pain, arm pain. Well, I'm going to have to do this while she's asleep. So let's go back to L4-5. We're in the right spot. The problem is it's so collapsed there that I need her asleep so I can dilate the disc space. Otherwise, it's going to be too painful for her. And she's going to tighten up her back muscles, clamp down on the disc, the vertebrae, the 2 vertebrae that are there, and close up the disc space, basically. So it'll limit my ability to gain access. Shot. So let's get that pedicles of 4 and 5 lined up nicely, the end plate lined up. So the goal is to cure her back pain. That's the goal of the surgery, cure back pain. And if the patient has leg pain or any symptoms from sciatica, to cure that as well. You're nowhere near where you need to be. So that's why we do the surgery. There's a lot of misinformation out there that somebody with scoliosis needs the scoliosis fixed. They need to have their spine curve put back in order to get pain relief. That's not true if the pain is coming from the disc, which we believe the pain is coming from her discs. Sean? Come on, Jordan. We got to get there. What are you doing to make progress? That's not bad. That's getting better. I don't know that that's better. The pedicle of 4 looks better. Let's see how collapsed it is on the CT. It's pretty collapsed. Yeah, all these disc spaces are collapsed. So none of them are easy to get to. I want to see that 4-5 a little better. I think the pedicle of 4 looks pretty good to me. And the pedicle of 5 is almost really good. It's not bad. I'm just wondering if we can open up the disc space a little bit, because there is a little bit of opening there. And it may not be WAG so much. Shot? Yeah, that's pretty good. It may be more of a orbital thing, but let's leave it for now. Let's see what I can do. Again, the spine is rotated away from us, so I have to go further to get to where we need to go. Are you comfortable, Sean? Good. Sean? Let's get an AP. May still be off too far. It's not bad. Not terrible. You can see the bone spurs coming off the end plate. You can see the disc space is open a little bit, a few millimeters. All right, back to a lateral. I'm looking for the pedicles, which I see. The pedicle of L4, the pedicle of L5. Spinous process. They're actually in pretty good position right now. Shot? I wish I had a little bit better view. It would require me to magnify. 4-5. I wonder what we can do to improve that. There's just so much curvature. Once we start moving one vertebrae with the flora, then we're going to end up affecting the view of the other because of the scoliosis between the two vertebrae. And remember, we're not here to fix her scoliosis. To fix scoliosis, we'd have to do pretty major surgery. Let's get an AP. Scoliosis correction involves osteotomies, inner body cages, inner body fusion, posterior fusion, and lots of instrumentation. It's not too bad. It looks pretty good. All right, let's yep. So we're close to being ready to put her to sleep, probably in the next 5 minutes. I just need to finish this needle. Let's go back to an AP, or can you pull up the AP picture? That's it right there? Yeah, it's just amazing, huh? That 3-4, there's no leg symptom at all. I may want to reposition that. All right, that's our current view up there.
Yes, sir.
Are you comfortable? All right. We're going to be able to put you to sleep soon. Just not yet. Close. Shot. Blood pressure's good. Yeah. I may not be able to. It's amazing, huh? 5'1", the hardest was. That's good. AP. Mm-hmm. That's better. Shot. Just don't like that one. Let's go back to a lateral. So I've gotten the positioning needles from the surface, the skin, to the backs of the discs where I want them. The problem is just getting in to the discs because of the collapse and bone spurs, thickened ligament from inflammation, etc. A lot of degenerative changes going on in the back of the discs, and those degenerative changes are basically blocking our needle from accessing the disc. So she relaxed a little bit and I was able to get it in. So the only one I'm not happy with at this time is the 3-4. Sean? And I can feel the back of the vertebrae. Nothing down the leg, right?
No.
Sean? I just don't know that we can do any better than that. So she did relax for 4-5. No, just can't. It's the angle of the dangle. All right. Are you comfortable? Yes? All right. How bad was that on a scale of 1 to 10? How high did it go? Can you ask her for me, please? She can probably hear you better than me. How high did the pain go? What's the highest it went?
7.
Is that where you typically get your pain? Huh?
Not where you normally get your pain?
Where you felt that, is that in your back? Is that where you typically get pain? The location?
No.
Okay. I don't know how reliable that is. How bad is that on a scale of 1 to 10? 8. Is that where you typically get your pain? Yeah. I think she typically gets it at both those levels. Unfortunately, I can't test the 3-4 because we're not in the disc space. We're right at the edge. So, I wonder, is that better? Are you more comfortable?
Yes.
You know, I'm going to try one more thing. Let me have another needle. And let me have some local.
Can I have a needle, please?
Local. Are you comfortable? I want to try one more thing. I want to try to go try a different angle for 3-4, see if I just can't get it in. Just a few more minutes and we're going to put you to sleep. There's a needle down here. So I probably could get 3-4 with what I've got once she's asleep. But I want to just try coming in at a little bit higher point and just see if I can access that space. A little better than I am now. Shot? Yeah, I think you're fine with the lateral view. Are you comfortable? All right. I'll let you know how everything's going well so far, Shot. Actually, better than I expected it to. Shot?
Yeah, no, it's fine. Thank you. Yeah.
Shot? That's the facet. That's for sure. So I meant the facet. Shot? 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 She has some big facets. Shot? Then again, Texas. Shot? Is that it? There we go. Yeah, it's very close. Shot? Very close. Shot? Where do you feel it? What'd she say?
In her leg.
In her leg. Is it gone?
It's gone.
Give me an AP. That's interesting. Blood pressure good? Yeah, I see. It's more lateral. Would you rotate your AP a little bit to get that spinous process just a little more lined up? Not much. Shot? That's a little better. That's funny, huh? Let's go a little more and see what happens. I want to see the pedicle on my side a little better at L4. Try the other way. Look how the pedicles are way off. Keep going. I think that's getting worse. Yeah, go the other way. Keep going. Let's go a little further. Yeah. All right. Are you comfortable? How's she doing? Going up? Yeah. Let's see if we can get that under better control. Huh? Shot. Go back to a lateral. Put a little pressure. Right here. Deep. Push. Give me a shot. Uh-huh. And where was the AP? That's it right there? Far. It's amazing, huh? That, okay. That 3-4 is tough. Shot. So I want to contact the facet, which I'm doing now. Shot. And I want to slip around it. Shot. No. Shot. I'm still on it. Shot. Where? I can't. All right. That's your facet. Facet frequently radiates or refers to the hip. Shot. You okay? Okay. Where? Ah. Damn it. So it looks like somehow. So what I'm getting, guys, is for those of you wondering if you know the anatomy, that's going to be the L3 nerve root. And give me an AP. That's what I was getting before. And I just can't proceed at that navigational array of points, line, because the L3 nerve root on the left side is in the way. So if you look at the pedicle of L3 up above the two needles, the nerve, it's so medial, it's because of the rotation of the spine, the nerve is kind of coming out and exiting down the leg, and that's what I'm hitting with the lateral needle. I'm hitting that root, or bumping it, which is causing her symptoms, and I just cannot get more medial. So I'm gonna have to go with my original needle, which, as funny as it looks, is our best option. Okay. And I have to decide if we're going to treat that. All right, let's go ahead and put her to sleep. So no discogram at 3-4 because we couldn't access the disc. All right, I like to start with 5-1, the hardest level, which today has proven to be the easiest. Can you count from 1 to 100 out loud, please? Count out loud from 1 to 100. All right, do your best with, she is. All right. Nice and slow, you're doing great. You need to rotate like this probably more. See what you can do. Not less, more. Try more first. Shot. Try a little more. I think that may have been worse, but let's see. Shot. Yeah, I think that's worse. Go the other way. can drop the fluoro more? Let's bring the table up half inch when you get a chance, please. Good. Shot. I think we need a little bit more of some rotational component, maybe. Keep going. She may have moved a little bit on the table. Alright, that's good. Alright. So at this point we're gonna take the needle out and leave the guide wire at 5-1. Shot. Shot. So I want to advance the guide wire. There it is. Okay, you're locked down on fluoro?
Yes, sir.
So the guide wire I could see at the front of the disc. I'm taking the needle out. Shot. Leaving the guide wire in place. The needle is a navigational tool. The guide wire is not. That's why we use the needle to navigate. It allows me some control over the direction of the needle that it goes because the surface is beveled. It's a little known fact. So at this point we're bringing our dilator down. Blood pressure is perfect. Could be a little lower, but it's fine where it is. It's 110 systolic. It's nice. Shot. And we're navigating past all the arthritis, the facet joints, into the foramen, and I know that we're in a safe place. I just don't like that sacrum. You guys doing okay? See if you drop your side, if that makes the sacrum a little better. Shot. It's not really a true lateral on the sacrum. Can't really tell if it got better or worse. Almost looks like it got worse. Can you give me other way? I need a picture. Try a little bit more, see what happens. Good. There's too much movement artifact. There's something shaking. Oh, it's her breathing. All right, shot. Again, you get blurrogram. All right, that'll do. It's not ideal, but it's adequate.
A question.
Sure.
A viewer is wondering, with the deformity in this patient's spine, is laser surgery going to really help them in the long term?
What was the question?
With the deformity in this patient's spine, I assume they're referring to the collapsed discs, is laser surgery going to actually help them in the long term?
Yes, laser surgery has a long-term benefit that is maintained. So this procedure you're watching, this is not laser surgery. This is the Duke laser disc repair. It's a very specific type of laser surgery. So you can't just say all laser surgery, because all laser surgery doesn't work. The Duke laser disc repair has been proven to work. And how is it proven to work? We've taken all the patients that were ever done. We looked at their outcomes from them, what they said they got in terms of pain relief. How much of your preoperative pain relief, how much of your preoperative pain did we get rid of with the surgery? That's the standard question. What percent of your preoperative pain is gone, or what percent remains, basically? And the answers range anywhere from about 50% up to 100%, with the preponderance of answers being 100%. And so when you look at the average pain relief across all patients that have this procedure, whether or not they have scoliosis, the patients with scoliosis do just as well as the patients without scoliosis, because the scoliosis has nothing to do with the cause of their pain. It's the disc herniation and annular tear that's the problem. And if you look at all those patients that have had pain relief, every single patient we've done has had pain relief. Their original preoperative pain is usually gone. And you take the average, it's about 95 to 98%. Depends on if you get everybody or certain populations. So there is no other spine surgery in the world that gives 95% elimination of back pain, except for the Duke laser disc repair. And don't confuse it with other laser surgeries, because there is no other laser surgery that does anything close to this procedure. Now, when you look at the long-term benefit, if you look at 5 years later, 6 years later, does the patient still have pain relief, the back pain relief? The answer is yes. There's really, I think it's good where it is, based on the lateral shot. So, in other words, the effect of the surgery is durable. It lasts. Durability is a measure of something's ability to last over time and different conditions. So, the durability of the surgery you're watching right now, we looked at our long-term outcomes in our patients. We studied them, and we found that when we did the study, we had, I think it was around 50 patients that had over an average of 6 years. They had to have a minimum of 5 years of follow-up, and they ended up with an average of 6 years. And those patients had 95% elimination of their back pain, the preoperative back pain. So that's called durability, long-term results. The long-term results of this procedure are excellent. There is no spine surgery in the world or treatment in the world better. If you know of anything better, bring it to me. Because I've studied artificial discs, I've studied fusions, different techniques. We've studied injections and needle procedures, rhizotomies, etc. And there is no treatment in the world, no yoga, no therapy, no rehab, nothing. Spinal cord stimulator, pump for pain, nothing gives long-term results as good as this procedure for back pain. But of course the back pain has to be coming from the discs. There are other causes, Shot. There are other causes of back pain. For example, infection would be a cause of back pain, but it's very rare that people have infections in their spine. Fractures are another cause of back pain. We don't treat fractures or infections or tumor pain with this procedure. This is not a surgery to treat pain that comes from fractures, tumors, or infection. That said, fractures, tumors, and infections account for probably less than 1% of people with chronic back pain. It's almost always from arthritis in the disc or facet joints. And most commonly, it's actually the disc is what we're finding. The spinal disc or disc herniation is the most common cause of chronic back pain. Remember, that's a chronic back pain, not acute. Acute means you get into a car wreck and you have back pain for a few days. That's usually muscular. We don't do this surgery for muscular pain. We do it for discogenic pain, pain from a disc herniation. So even this lady with collapsed discs, she still has disc material. She still has a disc herniation. And most importantly, she has an annular tear, which is a tear in the annulus fibrosus, which is the band around the nucleus or jelly. It holds the jelly in place inside the disc. And the annulus fibrosus is where this patient's pain is coming from. It's called an annular tear. You're going to see it. It's right here. See that tear right there? There's white, and there's a tear. And it's stained blue. Now, I just passed the instrument through the tear because that's the beauty of this surgery too, is that we don't damage normal parts of the disc. We go right through the tear because we come right through the herniation. The herniation comes out the tear. So we basically go in and push the herniation back through the tear, and then we take the herniation out from inside the disc. That technique was taught to me by Dr. Anthony Young, the removal of the herniation from an inside the disc to outside the disc technique. There are other techniques with endoscopic surgery where you can actually start in the foramen and work your way into the disc herniation, which is not a safer technique, and it's not a very good technique. That was developed by a different doctor. So here's the annular tear. Dr. Knight was his name, Martin Knight. Martin Knight. All right. He was a proponent of the outside-in technique, whereas most popular technique, I think, today is inside-out. And there are, surgeons around the world that do endoscopic transforaminal surgery, but nobody does an annular debridement. And the Duke Spine Institute is the first and the only one to describe it in the literature, have it peer-reviewed and published as a technique. It's all FDA approved. And so we're curing back pain, whereas other people are only basically curing leg pain. We cure back and leg, they cure just leg. That's the big difference. So why? Why aren't we fixing scoliosis? Because we don't need to. Scoliosis surgery, this is the tear, by the way. This is the source of her pain in her back. So remember we tested L3-S1 and she said, yeah, that's my typical pain. L4-5 is also painful, and I believe that's a source of her pain as well. But she said no, but I think it is. Unfortunately, I don't think that was a very reliable answer. And the reliability changes because of the circumstances, right? We're in the operating room. We've got her laying on her belly. We're giving her pain meds at times. So, we have to be cautious about how we interpret our results. And then the 3-4 disc I couldn't even test because I'm not in the disc. We're just outside of it. So, long story short, this patient doesn't need a scoliosis surgery to get rid of her back pain. She'll still have scoliosis. The scoliosis is relatively stable, okay? It's not unstable scoliosis. It's called glacial instability, meaning that it shifts over time, over many, many years, like a glacier, moving down a valley. That's just a little bit of bleeding from the bone, from a bone spur that I just zapped. But here's the tear that I'm working on right now. It's just below the little bleeding we got, to the right of it. And I apologize for the bad view. Fortunately, I've done a couple of these, so I know what to do. Is she moving? Yeah. All right, so that's not much fun. Let's get the grabber, take the laser.
We have another question.
Yes.
A viewer from Periscope is wondering, will having a spinal fusion get rid of back pain or just leg pain?
Will having a spinal fusion get rid of back pain or just leg pain? That's the question from Periscope viewer. Let me see the grabber again. So I'm going to answer this in a way to hopefully help you understand. This is very important. If the spinal fusion is not done properly, it won't get rid of back pain or leg pain. Okay? So this is a complicated answer. And it's complicated because it's a complicated answer in real life. I'm not trying to make it complicated. I do spinal fusions. I've done them for many years. I'm very, very good at spinal fusions. So if the spinal fusion is done properly, it will get rid of back pain. Now, to get rid of leg pain, you have to unpinch the nerves during the spinal fusion. And that part of the surgery is called a decompression. So if the surgeon doesn't do a decompression during the surgery and unpinch the nerves with a decompression to treat the stenosis that's causing the leg pain, the patient won't experience relief of leg symptoms. And as a matter of fact, if the decompression is not done during a fusion surgery when it's needed, if it's not done, the patient will actually have new leg symptoms that they didn't have going into the surgery, or worse leg symptoms like weakness, numbness. So all spine surgery you have to think about traditionally as being 3 different categories until the Duke laser disc repair came, which is a completely different category. Now you see that little trick, how I put the grabber in there, it stops the bleeding? That's because I'm giving some back pressure. There's some herniated disc, by the way, I'm taking out. The back pressure works because the bleeding is coming from a vein, not an artery. And whenever you have bleeding from a vein, it bleeds at about 10 millimeters of mercury pressure. And so by putting in this little guy here, this grabber, I basically obstruct the outflow of the liquid from the tube, and therefore I create a back pressure situation by blocking the outflow. I hope to God that's not the lens. And that needs to go as well. That's the tear. So I'm creating a back pressure situation by filling my endoscopic tube with the grabber, with the pituitary rongeur. And that creates back pressure. And that back pressure fights against the bleeding coming out of the vein. Such a weird effect here, Luis. Take. Do we have adequate pressure?
Yes.
What am I looking at there, Luis? Does that look like a lens issue to you? What do you think? Huh?
I can tell. I mean, you want a needle scope?
Here, hold on. Let me see the radic. What do you think? That looks like a lens issue, right? Let's get another scope. All right, we're just going to take a minute here. Let's see if we can stop a little of this venous ooze. The bleeding we're getting is like literally minuscule drops of blood. It's nothing. So it's nothing in terms of blood loss for the patient, but it's obscuring a little my view, which I still know how to do the surgery even with a little bit of bleeding like that. So it's not a concern in terms of blood loss or my capability, but I want to be able to see clearer. So I'm going to, we're going to take a minute. It's not for the bleeding. We're going to change the scope. The scope itself looks like it could be that one of the lenses has shifted, which sucks because A, we have to get another one, but B, these scopes are very expensive to repair. And what I mean by repair is when these little lenses shift inside the tube. Can you see, Sean?
Yes, we can.
You see this scope?
Yes.
There's a lens system inside that runs from a lens here to a lens here, and one of those lenses has shifted its position, I believe, which explains why. And it does happen because they're glued in there, and the glue gets old after a while of use, and then you have to take it back to the shop and
Lights on, please. Whoa,
let them, hold on, I got it. I'll put the irrigation on. You have to let them repair it. So the way you know that happens is when you see kind of a halo. You'll know. I've seen enough of them. I think that's our problem. Let's see the Raytech. That's better. You see how there's no halo with that one? If you have to go back and rewind, you'll see what I'm talking about. But basically the lens is shifted out of position. So I could keep going, but truth is that I'd rather have a better view. All right, so let's go down the tube, and that little venous thing still oozing a little bit. Take this. All right, so we're inside the disc, just at the outside part of it. You can see.
I'm sorry, what?
It's me. She wants me to adjust. Fine, move please. Thanks. Let's get our laser back on. Well, unfortunately, this happens sometimes where the oozing from the little bleeding end plate or bone spur or little epidural vein, whatever it is just wants to obscure the view, and we have to deal with it. So there's not much I can do about it. So just bear with us, folks. It's a good time to ask questions if you have any. Stand by. So that is kind of just about done with this disc. We removed the herniation fragments, and let me have the grabber again.
Yes, sir.
The pain in the ass. Come on. Come on. Stop fucking around, Luis. Get it right when it comes out. All right, there's the epidural fat at the top, and this will be the last of the herniation right here. Okay, so we're going to have to take this out again. We're going to end up with all that. Come on, Luis. You know what I'm going to be doing, so just be prepared. Pull the fluoro back. It's hitting the laser cable. Come on, faster. All right. How is she doing? What is it?
120, just off the 120. I want to get back down to 105.
That's where I want it, but it'd be nice if it was. Probably wouldn't have as much oozing. And the irrigation is cold, right?
It is.
So we're getting a little bit of particulate matter from the herniation that I'm zapping away at, and that's what's also clouding the view, but most of it is just red blood cells. Again, you can see the epidural vein. We're just about outside the disc. I'm pushing back in a little bit. Just finish this last section up and we'll be done. Again, this is the L3-S1. I started at L3-S1. Next will be L4-5. And then we're going to have a look at 3-4. As long as I can safely get in there, we'll do it. I feel pretty good because we confirmed that this L3-S1 is definitely the cause of her pain. So we did a discogram. It's a very good test. It's part of the Duke laser disc repair procedure is to do a discogram, and when you can. And the discogram is a procedure where once I get the needle in position inside the disc, passing through the herniation and the annular tear, I inject a little bit of dye. It's two types of dye. One is a visible blue dye. It stains to degenerated disc. And the other one is a radiographic dye. It's called Omnipaque. Isn't that what we're using? Luis, Omnipaque?
Omnipaque, yes.
Yeah.
Indigo Karma, yeah.
And the Omnipaque basically is pretty standard X-ray dye. It allows us to see on the X-ray picture the center of the disc and the tear. And if you go back and look and rewind, you'll be able to see where the black dye on the x-ray picture was leaking out through tears in the disc. Those are annular tears, okay? And that's what we're here to fix and debride, is the annular tear, especially the one where the herniation came out of, in the back of the disc. It's called the posterolateral annular tear. Just about done. That's the end plate to the left, end plate of 5. We have a little fumarole down here. Anybody know what a fumarole is? Let's see who has some training in marine biology. The fumaroles are at the bottom of the ocean. Stand by. They're those places where the let's have the grabber, where the thermal vents basically release very hot liquids on the ocean floor. All right, we had some good questions this morning, and I want to do a little more right here. Come on, quickly. See what happens if you wait too long? The view goes away. The whole point is for me to be able to see it. Luis, you understand?
I understand, yes, sir.
So you got to move a little quicker. You know, when you're walking through the jungle and it's the Vietnam War and you're on the United States military, you're carrying a gun, and it's nice and calm and quiet, you walk slowly. But then when people start shooting at you, you start running. Okay? This is when it's bleeding like this, you don't walk, you run. So this is time to move quicker. Okay? Not have the nice, calm, slow handoff. It's a quick handoff, so that I can get there before the view goes away. Okay? It's called adapting, adjusting, changing. If you don't adapt in life, then you die. I don't mean physically die. I mean your business dies, you intellectually die, you emotionally die. You're dead. Dead things don't adapt. Life adapts. Charles Darwin. Yes. Sean, you have a question.
Yes, we have a question from a Facebook viewer who asks, how can you rule out for sure that bone spurs are not causing some of her nerve root compression?
How can I rule out for sure that bone spurs are not causing some of her nerve root compression? Great question. So, when you've been doing it long enough, like I have with 25 years of experience, you learn that they don't. They don't, not in this area, and you learn which bone spurs do. Bone spurs rarely ever cause nerve root compression. Rarely. It's usually soft disc material. Okay? So that's rule number 1. So the whole notion that bone spurs are the cause of pinched nerves all the time, that's extremely rare that that happens. Bone spurs rarely cause pinched nerves. What causes pinched nerve is usually going to be herniated disc material. And number 2, what are you really talking about? Okay? You're talking about leg symptoms, right? Sciatica. What percentage of sciatica pain comes from compression, which is what a bone spur does? It compresses, it pushes. What percentage of sciatica pain comes from compression versus inflammation? So this is not something you've been exposed to before. Whoever's asking the question, they clearly don't know about this issue. The difference between compression and inflammation. So I don't know who you are asking, and that's fine. It doesn't matter who you are. What matters is that you leave here understanding that most sciatic pain is not due to bone spur compression of nerves. So if that's what you came here believing, then you should go away knowing the truth, which is that bone spurs don't cause nerve symptoms very commonly. It's extremely rare. So what causes nerve root symptoms, which is your sciatica, your leg pain, your arm pain, your tingling, potentially numbness, and even weakness? What causes it is inflammation. Inflammation of the nerve root. So, knowing that, can bone spurs cause inflammation of the nerve root? The answer is no. They can only cause compression of the nerve root. Bone spurs don't cause inflammation of the nerve root. So, removing bone spurs doesn't fix the patient, okay? Removing the source of inflammation does. And the source of inflammation is the annular tear that I just got through debriding. The annular tear. Okay? So, bone spurs rarely ever need to be treated. They need to be treated when they're causing severe compression of nerve roots and spinal cord. Is she doing okay? Huh? All right, should I proceed or wait? All right, you just tell me when to wait. Yeah, that's fine. I just want to make sure you have the opportunity to have me stop and wait. Shot? So, most important thing to understand is that sciatic pain, arm pain, any kind of radicular pain, pain radiating down the arm leg or around the rib cage from the thoracic, is 95% of the time going to be caused by inflammation, not bone spurs. So that said, the laser itself is capable of removing bone spurs, and we do. Almost every surgery I do, I take a little bit of bone spur away. All right, you just didn't see it. Maybe if this is the only time you've watched one of these surgeries, you might not have seen it because it was hard to see with that blood coming from that little fumarole, okay? And but normally people who watch these surgeries, they could see that we do shave down bone spurs that are right near the nerve. And this laser can cut through steel. So if you're wondering, does it cut through bone spurs? There's very little this laser won't cut through. And we only have it at 20 watts, 30 watts. We have it at 30 watts. And I think it's a 100-watt laser, right? So we could crank it up if we want to. But even at 30 watts, it'll melt steel, stainless steel. So which is harder to get rid of, steel or a bone spur? Bone spurs are easier, much easier than steel. So yeah, these lasers cut through bone spurs. I don't know, there used to be rumors going around out there, misinformation as there's so much, that the laser can't cut through bone spurs, but it can. Do it all the time. All right, I don't know if that answered your question or if it's sprung up a new question, but if it did, let me know. I'll be happy to keep trying to answer your questions for you. By the way, that's why we broadcast these surgeries, is to dispel the myths. There's so much misinformation about spine pain, back pain, neck pain, arm pain, leg pain, sciatica, radiculopathy, you name it. There's so much misinformation out there about it that's why we do the broadcast, is so we can change the way people think to reality. Get you away from all the false information. If let me ask you a question. If everybody out there really understood the cause of back and neck pain and sciatica, then why are there so many people living with chronic back pain even after being treated? The reason is simple. The doctors treating it don't really understand the cause. Shot? And because they don't know the cause, they can't possibly come up with a solution. I mean, sometimes you get lucky and get a solution to a problem that you don't even understand. Shot? Okay, I'm trying to take the needle out and leave the guide wire in. We're at L4-5. You can see there's still a lot of dye trapped in that disc, right? That's the black stuff in there, okay? So if you don't know where we are, Shot, we're at the second needle, the bottom one. And that is the L4-5 level. There we go. I just took the needle back. You can see a change now. And you still see there's a guide wire there. I'm taking the needle out, but leaving the guide wire. So now we use this beautiful guide wire to guide us from the skin down to the disc. All right? So can you guys see this, Sean? You want to show our viewers what it looks like?
Yes, we can.
It looks like a long metal pencil, but it's got a hole in the end, and that hole allows it to pass over the guide wire into the spine. It's funny because you show this surgery to most spine surgeons, about 98% of them have never seen this done before. I've been doing this for 15 years, going on 16 years now. This is the future of spine surgery right here. This is what everybody will be doing. Basically the Duke laser disc repair. Why? Because it works and it's safe and it's the least invasive surgery in the world for fixing this kind of problem. Every other surgery out there is more invasive, and the ones that you say, well, they have the mild procedure, right? The mild procedures is not a good procedure. It's garbage. But basically, why do people know about it? Because the company that makes the instruments and the supplies makes a lot of money selling them. And so they've learned that they can actually teach unqualified doctors, like interventional pain management doctors, basically to do spine surgery using their product. And of course those doctors are happy to do spine surgery because they're not surgeons. And somehow they've hit the jackpot. Now they're doing spine surgery, even though they're not qualified to do spine surgery. Right? And they're getting away with it. Why? Because big business wants to make money, and big business is making money on selling the mild procedure. I'm not ready yet. I just want to pull this guide wire back a little bit. Shot. So the guide wire is just getting pinched a little bit. Shot. Is she still comfortable?
Yeah.
All right, take that. Give me 1 second. Take. Shot. Shot. All right, so just give me a minute, folks. So what I'm getting at is there are now procedures being done on people with FDA-approved devices and equipment and being promoted and marketed by big business to make profits that don't work. These procedures don't work. And they do more harm than good a lot of times because the people doing them are not really qualified to be doing them. And so non-surgeons, unless they're very, very properly trained to be surgeons, should not be doing surgical procedures. But unfortunately, surgical procedures pay well, and so you have non-surgeons that are trying to do surgical procedures motivated by one thing, and that's money. And so they're doing procedures that don't work, but they're on the border of something that they could try. Like, you'll never see an anesthesiologist doing, screws and rods on a patient's spine. Okay? At least you shouldn't. But they may try something like this because it's closer to being a pain procedure rather than an instrumented surgery. And that's what I'm saying. You just got to be careful that the person doing your treatment is qualified and well trained, not just to do that procedure, but to manage potential complications that can occur as a result of doing the procedure. So for example, Shot, if an anesthesiologist were doing this, I would be very concerned, because that anesthesiologist is not going to be able to open the patient up and fix the patient if there's a complication, okay, whereas a surgeon can. So that's always been the rule in medicine, is that if you're going to do a procedure, a surgical procedure, that you're properly trained and come on, Jordan, I'm hitting this thing, get it out of there, pull it back. Is there any reason you're just leaving it right here? Pull it back. Please don't try to change the way I do things without a very good reason. Pull it back further. Okay? Okay, look, Jordan, what's the purpose of pulling the fluoro out? So I have room, right? And who else needs room? Thank you. So why would you put it so close to his unsterile head so that he can rub against it? There you go. Now that's smart. You see? And that's the way it's supposed to be every single time. You know, in surgery, we figure out things, and we don't like to have to refigure them out again because somebody decides not to follow what we want them to do. All right. Just a lot of blue. This is a very collapsed space, as was 5-1, the one we did already. And there's really not much disc left in here. So what I need to do is find the tear, which is going to require me to basically pull this tube back a little bit. And it's really tight. It's tight because the two vertebrae end plates are collapsing down. Do we have good pressure? You're looking at the end plates there, folks. That's the end plate of, on the left is 4, and on the right is 5. Now that's actually a bone spur inside, just inside the annulus on the left there. Okay? Now, that's not pushing on a nerve, but there is some inflammatory tissue on it that I want to try to address. So there's a lot of bubbles still. Okay? All right. It's actually more scar tissue than bone spur. But there's definitely a bone spur there. It's just not big. So I'm coming. There it is. That's what I came for. Right there. Okay? I love it. So beautiful. Man. So, all the scoliosis, collapsed disc, facet arthropathy, hypertrophy, deformity, herniated disc, degenerated disc, everything. It all boils down to this one little monster right here. I feel like sometimes hunting Medusa, except Medusa has no chance with this laser, right? Who killed Medusa?
Well, herself, right?
What?
Well, herself with no, what's with the
Let's
mirror,
see, who
she-
killed Medusa? You can't look at Medusa, otherwise you get turned to stone. So Medusa is a hideous monster, creating all kinds of pain and suffering. And many brave warriors tried to kill her, but got turned to stone because she was very sneaky, well hidden. Who killed Medusa? Circeus? I don't think so. Perseus. Very good. Sean, do we have any answers from our audience?
We do not.
Shameful. I am disappointed with the audience today. You could just jump on your computer and look it up. I didn't say you couldn't cheat. All right. Perseus was his father was Zeus. He was half human, half god. Anybody know what those people are called?
A demigod?
Demigods, yes. All right. Enough with the Greek mythology. So, we came into this cave, this tunnel, this chamber, and we found Medusa, the source of this patient's pain at this disc, in this realm, in this region. And we took care of Medusa. Okay? So, her pain will be gone. Now I have to decide what to do about L3-4. That's a tough one. I'm going to try and get in there. Okay. We're at the back of the disc, in case you're wondering. This is the back of the L4-5 disc. That's the epidural space. Again, veins. And really, there's not much disc left. It's all pretty much empty, right? Except there was that one little thing. And that one little thing was the annular tear. That was the source of this patient's pain. So here's the thing, folks. The knowledge I'm giving you about how to cure this back pain is not known to everyone. And it's going to take a long time for that knowledge to disperse. And that's a shame, because there's going to be a lot of people suffering needlessly as a result of this knowledge that I'm trying to impart to my colleagues and to you, the patients, the healthcare providers out there, the world. This little bit of information is not something that's commonly known. And there are so many forces at play to prevent it from being shared and distributed around the world. So there are many forces that don't want this procedure to be done. Namely, one of them being the implant companies, the companies that manufacture screws and rods. If this patient had gone to a surgeon anywhere else, she would have been offered fusion surgery. They would have been opening her up with a big incision and putting in hardware. Why? Because hardware makes money. Screws and rods cost money. Just the hardware alone on this surgery is more than the cost of the laser surgery being done. Just the hardware. That doesn't include all the other costs associated with fusions of this type. So the companies that manufacture the screws, rods, artificial discs, metal, plastic, bone graft, anything that goes into a patient like this that has bad back pain and deformity, anything that goes in makes money for companies. But the Duke laser disc repair procedure doesn't put anything in currently in the year 2021. So when I started doing these surgeries 15, almost 16 years ago, until today, we don't put any implants in. It's a natural disc repair. So the companies are not happy with me for creating a surgery that doesn't use their implants. That's really what it comes down to, because they're losing a lot of money. And they have investors and stockholders that rely on their stocks to go up in value so that they can make money in the stock market, Wall Street. So basically we have Wall Street against us, we have the implant companies against us, and the implant companies control most of the neurosurgical and spine surgery societies, like the American Association of Orthopedic Surgeons, the American Association of Neurological Surgeons. Those societies get donations every year, millions, tens of millions of dollars That's their main source of funding, is from the implant companies. So they're protecting that funding by supporting the implant companies. So you have the national societies that oversee and educate all of the neurosurgeons and orthopedic surgeons around, basically around the world. They're all beholden and controlled by the implant companies. So we've got Wall Street, we've got educational system, because the implant companies go to the universities and they donate to the universities that are training the new surgeons coming out, the residents they're called. And they basically are controlling the educational agenda because they control the faculty. You see the faculty at universities that train residents, they're all on the payroll for the implant companies. That's why when you look at what's called their disclosure, we got a problem. There's a little bone in there. When you look at the financial disclosure of surgeons that are at universities as faculty, that are at the meetings teaching other surgeons, that are the ones giving presentations about how to put in screws and rods and cages and the newest implants, all of them are on the take. They're getting their pockets lined with millions and millions and millions of dollars by these companies to promote the use of implants. I don't get any money from anyone to promote this procedure. Even the company that makes this stuff is so poor out of Germany, and they won't give you a dime to promote their product. So I've never taken money, and I probably never will get any money because there's no implants going in here. It's just go in and fix the disc tear, cure the back pain, cure the leg pain, but there's no company supporting me or helping me. So I'm alone, pretty much against the entire educational system, the implant companies. The politicians get their donations from these implant companies, so they're supporting the implant companies. The educational system, the university supports them. The societies, like the American Anesthesia Society, they would be, not them, but the equal in neurosurgery, which is the American Association of Neurological Surgeons, they support them. Shot? So who's on the side of this new technology? Just me, trying to educate the patients. The patients are on the side because they don't want the screws and rods. They don't want the cages. They don't want the big surgeries and the metal implants and the fusions. They want least invasive, most successful treatment. And that's why we broadcast this particular surgery, is to educate people about that. All right, let's see where we are. Let's go with an AP. So the reason I'm not getting aggressive with the mallet, banging this thing in, is because I'm not really anchored well at the end. I'm just kind of at the back of the disc, but barely hanging on. And so I don't want to start banging this thing because it'll shift the end point, which is my final destination. And I don't necessarily want to shift that out of its current position, even though it looks a little medial, but it really isn't. It's just the rotation. So let's go back to a lateral. Once again, I'm on the fence on this level only because I feel confident we've already treated her 2 painful levels. This level certainly could be painful, but I'm also not getting access to it in the way that I feel most comfortable. So I may want to, rather than risk having a complication, I want to probably assess how valuable it is to get in there and do this. But that's why I'm going slow and taking my time. Shot? Now, she never complained of any leg symptoms when I did this, so, but that doesn't mean 100% you're home free. That's why you have the patient awake, is to check. She's pretty good and deep, because I'm about to give her some stimulation, and I want to, well, I don't know that she needs anything at all. I just want to warn you, you know. Shot. So we're right there. And I don't feel anything soft down there. It feels pretty standard, like I'm pushing through herniation behind the disc. But Sean, and the fact that she's quiet and comfortable right now is somewhat reassuring. Like I said, we'll see. This particular disc is extremely collapsed on my side. So it's not surprising to me, Shot, that we're having trouble getting in. Shot? Not really. It's definitely opening the disc up. Yeah, it went in. That's for sure. Let me see. Very tight though, but we're in. Let me do a little, yeah. We're not going to have the blue dye to guide us, but we're definitely in. I got it. Thank you, Luis. We need probably about 10 minutes, we'll be done. So it's not often that I go talking about some of the other kind of peripheral issues in spine, but you know, people need to know the truth. And the truth is that we now have the technology to cure back and neck pain, and it really is less invasive. Fusion alone, there was a question earlier about fusion. Fusion alone doesn't fix leg symptoms, doesn't fix sciatica. If I have a patient with sciatic pain or leg pain or even arm pain, fusion, if you fuse their spine, you're basically going to fuse it in a place where the nerve is being constantly pinched or irritated. So you have to do a decompression first. You have to unpinch the nerve. And unpinching the nerve doesn't mean just removing a bone spur or herniation. Unpinching the nerve is more complicated. It actually involves changing the entire structure of the disc from where it is preoperatively, where it may be collapsed, and the hole where the nerve comes out, called the neuroforamen, may be compromised, okay? And what that means is the hole where the nerve comes out may be narrow because the disc is collapsed. And so by reopening the disc, by putting in a spacer into the disc space, you basically distract the pedicles, which are the top and bottom of the foramen. You distract them apart, and you basically create more space for that nerve going out the foramen. So I don't want to get into a lot of the technical anatomy, but if you just fuse the spine, you will not fix the leg symptoms or arm symptoms. You must decompress and realign. Realignment and decompression are very important. Now, if the patient has inflammation as the cause, then just going in with the laser and removing the source of inflammation in the back of the disc, which is the annular tear, will get rid of the leg symptoms, arm symptoms, as well as the axial pain. That's the pain in their back or neck. So that's why the surgery is so amazing. It fixes everything that fusion fixes, everything that artificial disc fixes. It just doesn't fix deformity. Deformity is basically correcting the scoliosis, kyphosis, listhesis. This surgery doesn't do that. But what I'm telling you is that patients don't need it done, because fixing the deformity doesn't fix their back pain and doesn't fix their leg and arm symptoms. Do I have schmutz on the end again? Can you wipe it, please? I hope I haven't shifted another lens. Do you think there's nothing different about your sterilization technique, right?
Oh, no.
You're doing everything the same.
Yes.
Okay. This is L3-4, by the way, in case you're wondering. We were able to successfully enter. And that's a lot to do with our anesthesiologists, believe it or not. So if you're going to start doing these surgeries in the future, if your patient is awake enough, they're going to be like literally tightening up their back muscles, squeezing, like trying to roll around to get away from the pain. You know, that's like so basic. I can't even begin to tell you. The development of extremities, arms, legs, came along much later in evolution, and core musculature, core movements of your core body, your axial body, are very, very old evolutionarily. So there are reflex systems in place. When you get pain, you move your core body, you wiggle it around like a worm trying to get away from that pain source. You know, much like an earthworm tries to get away. And so when you start stimulating the patient with pain going into the disc, they're going to start worming around on the table, wiggling and worming. And that causes their axial musculature to tighten up. And that axial musculature is what compresses the bones together in your vertebrae, your spine, you know? It pulls your bones down on top of each other. It basically collapses the disc space. And that is actually what causes the jelly to squeeze out of the disc space in the first place. When you have an annular tear, to get a herniation, you need the jelly squeezing out. This is the herniation, by the way, at this level. It's not blue because we didn't get any dye in here, but it's white, like most herniations are, kind of a beige, off-white. But so just going back to what we were saying, I need the patient to be comfortable, not feeling or responding to the pain. And I can't give them muscle relaxers because we need them to breathe. And giving a patient, you know, muscle relaxation like you see with general surgery, they would basically die from asphyxia, not breathing, because we've paralyzed their skeletal muscles. So we don't do that. We just need to work with you know, technique and level of sedation rather than muscle relaxation, because I need them breathing. This is the end of it right here. This was really hard to get into, as you remember. I tried a more top, going up to the top, going a little more medial. It didn't work. So this, actually I got lucky again. This is the annular tear. This is the end of it. We're almost done. I need 5 minutes and we'll be done. So how do I know we don't need to fix the scoliosis? How do I know we don't need to remove the bone spurs? Those are all great questions. I used to ask them the same questions years ago. But the truth is that my understanding that I'm giving you about this surgery and how it works is only because of my observations of the surgery and its outcomes. In other words, I didn't theorize this stuff and then go create a surgery that goes along with my theories and it's different than what everybody else is doing. I actually did different from everybody else. I observed that the patients did better and had better outcomes than standard surgery, traditional surgeries like fusions, decompressions, laminectomies. And then I started to ask why. How is this possible? As a scientist, you're always asking why. You make an observation about the real world and you ask why. Why does this happen? And it's all about being honest with yourself and honest about the physical universe and what's going on around you. You know, you have to be honest. You have to accept the fact that you don't know everything and that there are things you don't understand, truths, truisms, and you have to seek them out and then answer them, do your best job of answering them. I've had 15 years to answer these questions with the laser surgery, and I think I've done a pretty good job because my theories have been proven over and over again to be true. The theory about the annular tear is no longer a theory, it's reality. It's reality because that's all we treat. We do an annular debridement. That's what's different about this surgery than any other spine surgery. that involves microdiscectomy, laminectomy, partial facetectomy, those surgeries don't do an annular debridement. Of course, when you get into fusions, artificial discs, reconstructive surgery, it's different. But in the simplest types of spine surgery that deal with herniated discs, they don't deal with the annular tear. They only deal with the herniation, which is why they're not effective at curing back pain or neck pain, because they don't deal with the tear. This surgery is the only surgery in the world that actually repairs the annular tear. Great job, everyone. We're done. So just in case you're wondering, scope off, this is not a beginner level surgery for if you're doing endoscopic surgery, okay? This is a level 10 out of 10. This is the highest, most complicated, most difficult. So if you're just starting out doing transforaminal endoscopic surgery, do not start with a case that's like this much scoliosis. You want to avoid scoliosis, you want to avoid listhesis, and you don't want your discs to be too collapsed. This patient had every feature, every anatomical feature that makes this surgery virtually impossible. And I'll tell you, the anesthesia is so important. Probably 8 out of 10 anesthesiologists I've seen and worked with in the past would not be able to get this patient to a level of stillness, not moving around, and relaxation where they're relaxed with their skeletal muscles to the level that I need to do this surgery. In other words, if the anesthesia isn't done right, there's no way I could have done this surgery. So I've had other anesthesiologists in the past that we've tried out where the patient would be worming around on the table or tightening up their back and compressing the disc. And thank God we have a good anesthesiologist. So thank you, everybody. Let's show the incision. It's pretty remarkable. We fixed 3 disc herniations with probably a 9 millimeter, maybe a centimeter incision this time. It's a little bigger than normal, only because I had to try to get a little more medial to get to 3-4. The higher up the spine you go, one of the secrets is the higher up the spine you go with discs that you're fixing, the more medial you need to start. Okay, so it's like that. This is the midline here. Now, had this patient had a fusion, which I do fusions all the time, I would have done an osteotomy to correct her deformity. I would have done interbody fusion, interbody cages with reconstruction, pedicle screws, rods, crosslinks, and decompressive laminectomy. The surgery itself would have been 5 hours, skin to skin, and that's fast, by the way. And it's probably one of the fastest in the world to do that. And the incision would have been this long, from here to here. You see that? Minimum, that long, and I would have split the muscles off the spine. So our incision today is, there's 50% of our blood loss right there. Our incision today is 1 centimeter, tiny. Did you guys see that, Sean?
Yes, we did.
All right, apply pressure, please. Great job, everyone. And she's going to go home an hour after recovering, rather than being laid up in bed for a few weeks because of pain from a fusion. Yes. Huh? Oh, what time is it? What's the next case?
All right, everyone, thank you for joining us for the post-op Q&A. Dr. Duke is going to join us in the room in just a moment. He's sitting down and getting his coffee. We're going to switch to his face cam so he can answer some of your post-op questions. Currently, we just have one question, so I'm going to transition to the face cam now, let Dr. Duke greet you, and then we'll continue with that question.
Well, good morning. We said it was February 9th, 2021. You guys hear me? Okay, Sean, they hear me? Okay, I'm Dr. Ara Duke-Majan, the CEO and founder of the Duke Spine Institute. So we had some good questions today about, what do you do about bone spurs, and can the laser take care of bone spurs? Yes, the laser can definitely fix any bone spur that needs to be fixed. The laser can melt metal, and fixing a bone spur, melting a bone spur down is easy. The problem with getting the bone spurs is that they bleed. So once you start getting into a bone spur, those bone spurs have a blood supply. So once you start shaving it down, it starts to bleed a little bit. And that's kind of what we saw a little bit of today, early on in the case, a little bleeding. When that, when it first happened to me and I got some bleeding years and years ago, it was more concerning than it is today. And the reason is that years and years ago, I didn't have as much experience as I do today. And so that experience of being in the endoscope, knowing the anatomy, knowing where the nerves are, where the end plates are, there's really not a whole lot going on down there. It's pretty much the same in everybody. There's, the vertebral body end plates. And for those of you who don't know what I'm referring to, can you hold this mic for me? Thanks, Sean. So if you look at the spine here, you've got these yellow vertebrae, right? These are bones. They're called vertebrae. And what we're fixing is the cushion between the bones. So take a look at this thing. As you move the bones, bend and twist, forward, backwards, side to side, and even some rotation, the cushion is compressed. It's pushed down on with that movement. And this cushion, we call it the disc, the spinal disc. Can they see okay, Sean? So when I'm in there with the endoscope, I'm actually inside the herniation, like where the tip of the toothpick is. And if you look this way, you see the bone here, and it's a flat surface. It's called the end plate. Let me just show you right here, okay? This is the end plate. It's called the end plate. That's the anatomical term for it, all right? And then above the disc, there's an end plate. So there's an end plate up here, and there's an end plate down here. But the end plate is referring to the entire surface of the vertebral body. And it's made out of cortical bone with cartilage on top, kind of a cartilaginous material. So, and then the jelly disc is wedged between those two bones. So when I'm inside and I'm looking this way left, I see the end plate, that surface there. I look the other way, I see the end plate up here. And then of course the annular tear is going to be right here in this part of the disc, right there. You all see that? Right in the back. That's the back of the disc to the side, back side. That's where the painful annular tears are, okay? If you have an annular tear on the side of the disc over here, it doesn't hurt. Front doesn't hurt. Side doesn't hurt. The only place that people have a painful disc is when it's in the back of the disc, along the back here. And that's because the nerve fibers to this part of the disc are different than the nerve fibers to the sides and front of the disc. The nerve fibers to the front and sides of the disc are called visceral afferent fibers, VA fibers. And they don't go to parts of the brain that can map out exactly where the pain is. So when you have inflammation here in the sides of the disc or front of the disc from an annular tear or herniation, that pain information goes to the brainstem. And basically the brainstem cannot tell where the pain's coming from. So it really basically just goes off like smoke into the air. It's not really interpreted. It doesn't create a change or physiological change in your body or your brain. On the other hand, tears in the back of the disc are innervated by somatic afferents, which are somatotopically organized on the brain. So they go to the opposite side of the brain and they map out exactly where it hurts. That's why you feel that back pain when your tear is in the back of the disc. That's the magic that comes from Duke Spine Institute. That wasn't taught to me. That's not known elsewhere. That is something that we synthesize and put together based on the sinovertebral nerve innervation of the back of the disc and carrying somatic afferent fibers up to the somatosensory cortex, primary somatosensory cortex. All right, so that was fun. tell me more. Tell me more about the question. What are they most interested in? Sean is afraid of the camera.
So the question really, it seems like the viewers are just curious about, because this patient had such degenerated discs, they're wondering, now that you've closed up the annular tear and removed that herniation, is the disc material going to regenerate itself? Will the spine correct its own deformity now that the injury is gone? Or will it just stay like that forever?
All right, so this patient's spine, and just ignore the metal because that's not here. This patient's spine is so twisted, I can't even do it to this because it'll rip everything apart. But her spine is so twisted to the side like a snake, all right? The surgery we did today didn't fix the twisting of the spine, not 1 ounce, not 1 iota, not 1 degree. We did not correct any deformity with her surgery. And the discs are still completely collapsed, bone on bone almost. But her back pain will be gone. Why? Because the back pain is not coming from the twisting spine, the slipping spine, the bone on bone. It's not coming from anything other than one tiny little tear in the back of the disc. And that's what I discovered at Duke Spine Institute. That's what we've published in the literature in the Duke laser disc repair procedure. It's the annular debridement that gets rid of the back pain. That's the magic about this procedure. We don't need to correct deformity. We don't need to correct kyphosis, listhesis, scoliosis, degenerated disc, collapsed disc. We don't need to put jelly back in. We don't need to do any of that stuff. All that stuff's being done by other surgeons all around the world in a desperate attempt to fix back pain. And it's not working, folks. That's why there's so many people that have had back surgeries, back treatments. It doesn't work. But the patients that leave Duke Spine Institute with a Duke laser disc repair, it does work. Their back pain does go away. So that said, no, we didn't even, today I didn't even close up the annular tear. We never do. All I do is clean up the annular tear. The tear is still there, and it's actually a little bigger when I'm done. The tear is a little bit bigger when I'm done debriding it. But the key difference is that the tear can now heal itself. It can actually, whereas before it was kind of ratty like this, I cleaned up these edges. Now it looks like this. Now it can heal because those ratty edges had nuclear material wedged in there called interposed nucleus pulposus, interposed herniation. And that was keeping the annular tear from resealing, okay? So I went in there and I cleaned all this up with a laser to get rid of it. And now you've got a clean edge and a clean edge that can close. And there's no more jelly wedged in there. That's why it can close. So I did a debridement of the annular tear. And the Duke laser disc repair, the procedure I created 16 years ago, that procedure is the only surgery in the world that actually does an annular debridement so the annular tear can heal. Everybody else is trying to take the herniations out here, okay? Let me show you what I'm talking about. This is a disc, okay? Sean, you want to grab my mic? This is a disc right here, okay? Normally you look at it like this, all right? So let's take a look. Right here. Bone, vertebrae, disc. There's the back of the disc where the tear is and the herniation. There's a nerve root that it's irritating. So I'm going to pull the disc out so we can look at it, okay? You see that? Can they see it okay? What happened to my toothpick? Let me grab another one. How does that look?
Right on center.
Good. All right, so you see the herniation? That's this lump right here. Every surgeon in the world is trying to take this lump out. That lump. But they stop right there. That's not the problem, folks. The problem is here, below the lump. I guess you could say it's the tip of the iceberg. That's not the iceberg. The problem isn't the tip of the iceberg. The problem is what's below the surface. Right here is where the annular tear is. That's the source of inflammation. That's the source of back pain or neck pain or thoracic pain. That's what I fix with the Duke laser disc repair. And I'm the only one doing it in the world. And that's why we're able to cure back pain. Other people are not, is because they're not doing it. Now, when you fuse the discs or you clean them out completely, sometimes the surgeons get lucky and they clean the annular tear up and then the pain goes away. But that's when they don't do that, when they don't clean up the annular tear, that's when patients continue to have back pain even after their surgery. Do you have another question? That was our only question. All right, great. So our next case is going to be a Duke laser disc repair, L3-4. This is a patient who has a herniated disc at 3-4 on the left side, and he's got back pain, and it radiates into the left side, the left leg. It's due to inflammation, not compression. We're going to go in there and do a single level Duke laser disc repair in about 20 minutes. Okay? Thanks for joining us, and bring your questions and type them up.